The first patient today has severe right hip arthritis. She's a very active fitness instructor who's been dealing with this for a long time.
I feel good.
Yeah?
I feel good.
Today's the big day?
I'm very excited to be out of pain. So, I trust Dr. Cohen.
We actually did her other hip replacement 2 years ago here at the East Bay Surgery Center, and the pain has gotten quite severe. She's now using crutches both at work and at home to get around, and she's tried everything else and she's ready for her hip replacement. So the plan is she'll come in around 6:15 in the morning, get checked in.
Reporting for duty. Your name, please? Jill Hedrick.
With Dr. Cohen?
Yes.
Hey, good morning, Ms. Hedrick.
Good morning, doctor.
How are you doing?
Very good. Can't wait for today.
All right, you ready to rock?
Ready to rock and roll.
All right, any questions for me about the surgery?
Nope. Feeling good.
She'll go to the preoperative area where she'll meet our preoperative nurse. They'll start an IV. She'll meet our anesthesiologist. So this is the first one of two. Today we do about 2 to 3 joint replacements a day, mostly in the morning, and then patients are home by the afternoon or in time for dinner with their loved ones. We really have the best crew. Everyone shows up to work and just, you can tell they really enjoy it, and I think that makes a wonderful experience not only in the OR but for the patients before and after surgery as well.
The star of the show.
Around 7:15, 7:30, we'll go back into the operating room where the anesthesiologist will provide spinal anesthesia for the hip replacement. We'll start the surgery somewhere around 8, and then that takes about an hour and a half. We use about a 3-inch incision right on the front of the hip. It's called the anterior approach. It's a minimally invasive approach where we work in between the muscles on the front of the hip. We're not cutting any of the muscles, which allows kind of a quicker recovery and a little less pain on the initial front end of the surgery. So we do all this through a small incision on the front of the hip. We actually cut and remove the hip part because that's no longer good anymore. That's the worn out piece of the bone. We have planned where we're going to put our cup, and we really have to reconstruct our cup part or our acetabulum because it's so worn out. And so we use special reamers to ream and replace the cup part. Once that's put in, sometimes it's anchored with a screw. We use a screw to anchor that into the bone. Then we go on to the femoral side to replace the femur. And how we do that is we actually access the canal and use a series of broaches that go into the femur until we find the correct size, which we already kind of know from our computer templating. This is also confirmed during the surgery. We have intraoperative fluoroscopy or intraoperative x-ray. We actually check everything. We make sure we like the sizes, we make sure we like the leg lengths, make sure we like the offset or how far apart the hip is from the body. All of these things we can kind of check intraoperatively and fine tune it. And then when we find the parts that we feel is best for the patient, that's what we go with, and we put those in there. It went great. There's great reconstruction of her hip. You know, she had some bone loss because she's been dealing with this for a long time, and it was a really severe hip arthritis. So we did a couple things to reconstruct her hip and make her legs even, and I'm really happy with how everything went. I think she's going to be thrilled too. It took about an hour and a half total from sleep to wake up, and she's headed to the recovery room now. Hi, Ms. Hedrick, how are you doing?
Very good. Awesome.
And then the patient will come out to the recovery unit or the PACU or post-operative care unit. Over the next hour or two, she'll have lunch, and we'll make sure her pain's well controlled.
The other thing that I do for you to make this as simple as possible is I do your schedule for your meds for you.
Thank you.
So I have each med, when you start it, and what's your schedule.
Once all those things have happened and she's recovered from her anesthesia, then the physical therapist will come work with her, where she'll walk, she'll do stairs, and make sure that she's ready to go home. We send her home in a private car, and then she gets to have dinner at home and ultimately sleep at home.
Nice car. Going in style. Feet together, you said, right?
Most people find that easier to do. It's going to be here to clear your toes if you need it.
Can you go back a little bit?
Bend.
Can I bend it?
Oh, absolutely.
There we
All
go.
right. Yay! I wish you the best.
Oh, thank
All right.
you. You
I wish
too.
you the best
Thank
recovery.
you so
It was so
much.
nice meeting you.
Hi, Dr. Cohen.
Hi, how are you?
I'm feeling great.
Good, just calling to make sure you made it home safely.
A physical therapist comes the following day to work with her, and we're in close contact with her as well, answering any questions about her treatment plan or medications.
Definitely better than when I walked in this morning.
Awesome. Well, listen, take it easy tonight.
Well, today's exactly 2. And I feel great, and I feel like every day better and better.
With each day, I just feel a little stronger, a little bit more normal, and a little bit more independent. Every day gets, even exponentially better. By today, I'm able to get dressed all on my own except for the sock on the foot. I can actually tie a shoe, but the sock on the foot is the most challenging thing. But I got everything else covered. Taking showers, getting up downstairs, sleeping in my bed.
Hey, good to see you. How you doing?
I'm doing great. I'm
Awesome.
doing a lot better than when I came in.
The pain is mostly at night when I'm tired. That's when I always feel my pain. But if I'm busy during the day, which luckily I've been able to be more mobile, it's not been bad, just been relying on Tylenol. Pain was 10 out of 10, and now the pain's like 2, 3 after a long day, night and day. I mean, I felt better the first day of surgery than the day I walked in, before the surgery. I am looking forward to feeling more my age of 58 versus 90. And being able to walk and not be in pain, and work and enjoy my profession and not be in pain, and to enjoy life without pain, because I felt it every day. So I actually already have moments, hours. I would say I have more hours no pain than hours in a day with pain, so I'm already making progress in 2 weeks. So I'm definitely getting closer and closer to 58. So that's the goal.